Welcome, and thanks for joining us for what I think will be a very engaging, highly relevant, clinically applicable program. My name is Lori Hoffman. I'm a strategy and leadership consultant for Calroy Health Sciences, and I'm privileged and bubbling with excitement to serve as moderator for today's endothelial health, an urgent clinical priority. Cardiovascular disease continues to be the leading cause of death for adults. And now with the COVID-19 pandemic, we're seeing a variety of vascular disorders correlated with worse COVID patient outcomes. As the industry leader in innovations to support endothelial health, Calroy Health Sciences is committed to offering educational opportunities such as today's webinar to shine a brighter light on the importance of a healthy endothelium and vascular system, and to present research-based clinical strategies to support a robust endothelial glycocalyx. I'm honored to introduce today's presenters, Dr. Sam Yannick, Dr. Mark Houston, and Dr. Christine Burke. Dr. Sam Yannick is CEO and Director of Education for CogensImmunology.com, an online functional immunology course that has 4,000 clinician participants from more than 60 countries around the world. He's an adjunct assistant professor in the program on integrative medicine in the Department of Physical Medicine and Rehabilitation at the University of North Carolina School of Medicine, where he teaches topics in functional immunology. With his wife, Cheryl Yannick, MD, a psychiatrist, Dr. Yannick runs the Yannick Center for Life and Health, a functional medicine clinic in Chapel Hill, North Carolina, where he's been seeing patients from everywhere since 1992. Dr. Yannick and colleagues recently published a functional medicine perspective on COVID-19 in the paper, Evidence Supporting a Phased Immunophysiological Approach to COVID-19, From Prevention Through Recovery. If you haven't seen that paper, it was published in IMCJ, Integrative Medicine, a Clinician's Journal, and I'm sure we can post the link in the chat. Dr. Mark Houston is the director of the Hypertension Institute and Vascular Biology, medical director of the Division of Human Nutrition and medical director of clinical research at the Hypertension Institute in Nashville, Tennessee. He's on the faculty and director of the Advanced Cardiovascular Modules for A4M, MMI, and is a clinical instructor in the Department of Physical Therapy and Healthcare Sciences at George Washington University School of Medicine and Health Sciences. Dr. Houston has 4 board certifications by the American Board of Internal Medicine, the American Society of Hypertension, the American Board of Anti-Aging and Regenerative Medicine, and the American Board of Cardiology, certification in hypertension cardiovascular disease. He was selected as one of the top physicians in the US in cardiovascular medicine in 2018 by the US Consumer Research Council. Today, he was also honored by USA Today as one of the most influential doctors in the US in both hypertension and hyperlipidemia, twice, in 2009 and 2010. And he was selected one of the top 100 physicians in the US by the American Health Council in 2017 and one of the top 50 functional and integrative medical doctors in the US in August of 2017. Dr. Houston has published over 250 medical articles and published 9 books, including the November 9, 2019 Personalized and Precision Integrative Cardiovascular Medicine. Dr. Christine Burke is a graduate of the UC Davis School of Medicine and UCD Family Medicine Residency Program. She's triple board certified in family medicine, sports medicine, and integrative medicine, as well as an IFM certified practitioner. She served 5 years as the chief of family medicine at Mercy Hospital of Folsom and is currently an assistant clinical professor of preventive medicine at Loma Linda School of Medicine, where she teaches in a functional medicine elective course for medical students. She's an educator for the Institute for Functional Medicine, working in several capacities over the years. Dr. Burke has spent her entire career as an entrepreneur in private practice, passionate about the reversal of chronic diseases such as heart disease, diabetes, and dementia. She continues to innovate the delivery of healthcare in her role as medical director and CEO of the True Health Center for Functional Medicine in El Dorado Hills, California. I hope you agree that we're enormously privileged and grateful for the opportunity to hear from these three highly accomplished, passionate clinicians, researchers, and thought leaders. And now I'm pleased to turn this over to Dr. Sam Yannick.
Thank you very much, Lori. I really appreciate it. I'm certainly pleased to be here in such good company. Let me see. Okay, so what I want to do in the next few minutes is just tee up the broad sense of how this fits into the overall picture of functional medicine. It's fairly compelling and straightforward, so let's get right at it. I do think that this is material that I think will be fairly intuitive for you when you see it. So there is a biological hierarchy of needs, right? And first on that list is oxygen. So if you can't breathe, nothing else matters. Glucose regulation, sleep, level of inflammation, none of that is relevant if you can't breathe, right? Everything else stops. So oxygen is literally at the center of everything. So there's oxygen, there's everything else. Temperature, water, pH, food, sleep, all the things that we think about as front and center in the functional medicine world, really ultimately they pale by comparison. And the way you can tell is that if you can't breathe, nothing else matters and it gets your full attention right away. Okay, so the other consideration in addition to oxygen when you're thinking about the circulatory system is the impact of circulatory compromise on everything else we do as functional medicine clinicians. So you can design a brilliant plan of nutrition for your patient, food, supplements, variety of things. But if you've got impaired delivery to tissue because of circulatory compromise, your results are going to be impaired to the extent of that compromise. On the other hand, the very, very same plan, when you restore circulatory integrity, is massively more efficient. So one of the ways to think about and understand the impact of restoration of circulatory integrity is that literally everything else that you do for the patient will work much better. Okay, now let's talk for a moment about COVID-19. When you do a deep dive into COVID-19, what you discover is that hypoxia is at the center of things, along with inflammation. Now, let me just telegraph where this conversation is going, at least my part of it. In the functional medicine world, we think a lot about inflammation. We think a lot about NF-kappa B being at the center of the inflammatory process. What we need to also realize in the functional medicine world, both in relation to COVID and broadly, is that hypoxia is also crucial. And hypoxia could be marginal, could be 5%, 2%. Any decrement of oxygen integrity is going to yield that, to that extent, some measure of hypoxia. That's going to trigger hypoxia-inducible factor 1 alpha. And HIF1 alpha and NF-kappa B are co-activators. And what that means then is, to the extent there is hypoxia, it will become a driver of inflammation. Now, we love to think about and examine and inventory all the factors that drive inflammation in our patients, and rightly so. And hypoxia and vascular dysregulation need to be front and center there because they are big drivers of inflammation. Now, how does that relate to COVID? Well, autopsies, this is an article sort of rolling together comments about several studies about coronavirus autopsies, and what they find is that the virus affects the endothelium. Now you can imagine then that having a healthy endothelium at baseline is going to confer an advantage, right? As you go into the process of being infected, what's your robustness like broadly? What's your robustness like immunologically? What's your robustness like in cardiovascular function? All of those things go into the quotient of how you do. So this is New England Journal of Medicine 2020, and they're talking about endothelialitis, thrombosis, and angiogenesis. So you can tell they're talking right away about the pulmonary vascular endothelium. And what it boils down to is that the lungs of COVID-19 patients have severe endothelial injury, and the alveolar capillaries have microthrombi. Now, so what's with the thrombotic effects? This is blood 2020. The thrombosis, the blood thickening, is driven by neutrophil extracellular traps, nets. Neutrophils come in and they release these things called nets. They are decondensed chromatin, literally they're meshes or nets, they call them nets for a reason, that are decorated with neutrophilic enzymes that destroy things like bacteria and viruses. The problem is that these nets form a third scaffold in addition to fibrin and von Willebrand factor, a third scaffold for platelet aggregation and therefore clotting. And the problem then is that the kind of inflammation that's involved in COVID-19 drives these nets, drives the formation of these nets, which drives the blood to get thick. Now you have microthrombi in the pulmonary capillaries. Now you're not circulating the blood through the lungs as efficiently. Now the O2 level goes down. But recognize hypoxia and NF-kappa B, right? HIF1 alpha and NF-kappa B are coactivators. Now, the inflammation gave rise to the nets that gave rise to the thrombosis and the clotting and the low O2, but now the low O2 is going to turn around and drive more inflammation. And you can see how this process can accelerate. And so there is the word here in the title, immunothrombosis. Immunothrombosis is this immunological drive toward vascular thrombosis. And it can set up a positive feedback loop that can become quite problematic in these severe cases. So in this context, you want to be concerned both about the inflammation and about the hypoxia. And overall, you want to be concerned about the vasculature and its lining, which is the endothelial glycocalyx that Dr. Houston is going to talk about. So this is another paper talking about the same thing, and interestingly talking about some lab markers that you can track in your patients. High sensitivity CRP, D-dimer, lactate dehydrogenase, and neutrophil count. And also you can track myeloid peroxidase, which is also mentioned here. Now, this is an older paper. It's not a COVID paper. It's about Nature Immunology. It's from Nature Immunology, and it makes the point that one of the things that happens with any kind of infection is that molecular oxygen is taken up by neutrophils and used to make superoxide, which the neutrophils then use to kill the pathogens. So there's going to be inherent in any infectious process some increment of hypoxia that is normal as a consequence of what the immune system is doing. So that hypoxia is going to drive HIF1 alpha. The HIF1 alpha is going to drive inflammation. The inflammation signaling is going to draw more neutrophils in, and that helps the process get going to kill something. All of that is normal if it's done in a balanced and normal way. Same paper, but remember, and the paper shows it here, NF-kappa B and HIF1 alpha activate each other. So as they say, NF-kappa B is an activator of HIF1 alpha and vice versa. That's where we get the HIF1 alpha NF-kappa B coactivation. Now, what does that mean? What does that imply? Well, when you have an infection and your O2 goes down so you can make superoxide, that hypoxia drives HIF1 alpha, drives NF-kappa B, which drives the inflammation that leads to the thrombosis that we were talking about before, the blood thickening up and so on. The problem is that if you have poor vascular integrity at baseline, then that very same cascade moves you closer to that thrombotic threshold. So if you are too close to that threshold already and you get an infection on top of that, then the risk of problematic thrombotic expression is potentially greater, and that's the concern. So to sum up, in functional medicine, we're certainly all over it in terms of the inflammation. We're totally on top of the inflammation, the NF-kappa B and so on. But really, it pays to be sensitized to the concern about O2. It pays to be sensitized to the need for paying attention to the vasculature. And that's all about hypoxia. It's all about HIF-1 alpha. Okay, so last thing to talk about is that patients with comorbidities have a much more severe expression of disease. So there's a Washington Post article across the top, and then below it is the underlying CDC reference. And then here are some papers talking about the specifics of the comorbidities. And really what it boils down to is hypertension, obesity, diabetes are front and center. And don't all of those have significant cardiovascular components, right? All of those are about cardiovascular risk factors and biological expression factors. Okay, so the vascular system is 60,000 miles of vessels. That's pretty crazy, right? And all of those vessels have this single cell lining called the endothelial glycocalyx. Now, I can tell you that as I've done the work of paying attention to COVID and co-authored the paper on COVID, it has gotten me more and more deeply interested in the relationship between the immunology and the cardiovascular physiology. These are deeply interconnected processes. And the work that Calroy and Dr. Chen have been doing with unfolding this story, I think is very, very important. It's very much worthwhile for us to learn more about it, get more involved in understanding it and thinking about it with our patients. I think it's a very important piece. And with that, what I want to do is turn this over to Dr. Houston. He's going to give us a deep dive into the endothelial glycocalyx.
First of all, thanks to Calroy for sponsoring this, and to my esteemed colleagues for their excellent information. So let's go back with the basics of vascular biology for a moment, and then we'll get into specifics of how this becomes a dysfunctional organ. The endothelium is a single layer of cells that has been talked about for years with endothelial function, production of nitric oxide, and other inflammatory markers, oxidative stress markers, and immune markers. A functional, healthy endothelium will actually protect you from cardiovascular disease. Outside the endothelial layer, though, is another important compound called the glycocalyx, which is really sugar coating. So this is I like to call it a bear coat, actually, to protect the endothelial lining. You can see these hair-like projections. That's your glycocalyx. And just under that, this would be your endothelial lining. So if the glycocalyx is damaged, then the next thing that will be damaged will be the endothelial lining. So both are important, and they both provide protection from the consequences of dysfunction of either. It's a very smart barrier, and it's very thin. It's very selective, that doesn't let things slide through very easily. It's very slippery. In fact, both the endothelial lining and the glycocalyx are like Teflon. Things just typically don't stick until they're injured. And it regulates all the factors that we've alluded to earlier, which is vascular permeability, leakage, inflammation, coagulation, fluid balance, oxidative stress, and immune dysfunction. It's like an air traffic control system. It actually determines what happens to the rest of the entire arterial structure based on blood flow, other factors in the production of nitric oxide, which is what determines really vascular health through cyclic AMP. This is a very busy slide, but you get the idea that the complexity of this is related to multiple interactions between monocytes, leukocytes, the glycocalyx, and the vascular endothelium. And within all of this are various proteins and molecules that are involved in all of these processes. So when we talk about nitric oxide, that's vasodilatory. When we talk about angiotensin II, that's vasoconstrictive. And there's always this very critical balance between vasoconstrictors, vasodilators, inflammation, anti-inflammation, and other things that have to be balanced very carefully, because if one gets out of control, then you have vascular disease. So glycocalyx, as shown here, is a group of negatively charged compounds in various glycoproteins that stick up out of the endothelial cell lining. And then those two connect directly to the vascular smooth muscle to determine whether or not it becomes thickened, damaged, vasoconstricted, that can cause hypertension, coronary vasospasm, myocardial infarction, or as pointed out previously, actual microthrombi in arteries throughout the entire body. These proteoglycans, there's 7 different types. And what they typically do is determine the backbone of the entire glycocalyx, and they limit the access of damaging molecules through that into the endothelial lining. But if those glycoproteins and proteoglycans are damaged in any way, whatever's in the bloodstream will sieve through and cause endothelial damage and vascular damage. So if you look at the things that are sitting out here, there's antithrombin 3, tissue factor, lipoprotein lipase, growth factors, superoxide anion, which is very important because that's what breaks down superoxide. Dismutase breaks it down into water. And you've got hyaluronic acid molecules. So all these are large proteoglycans that are like finger projections out into the vascular lumen. So as blood flow and blood pressure change, it will instigate a formational change and a structural change in both the glycocalyx and the endothelial lining, to the point that all of these different molecules can go haywire, which leads basically to glycocalyx dysfunction and endothelial dysfunction. And then that leads to all the cardiovascular events, which are myocardial infarction, coronary heart disease, plaque formation, stroke, renal failure, and other illnesses. If you look at the plasma proteins that are circulating, the red cells, the white cells, most of the time these will just bounce along the lining. They do not stick. But if there's some sort of damage, then the white cells will stick to the glycocalyx and then to the endothelial lining. And that is the beginning of the endothelial dysfunction and the formation of arterial plaque. So all of the proteins will do the things listed here below, which are basically the 5 things we've talked about earlier: reduce inflammation, reduce oxidative stress, reduce vascular immune dysfunction, prevent thrombosis, and prevent platelet adherence and leukocyte adhesion. Once that happens, the nitric oxide levels start to drop dramatically. Oxidative stress goes up. Then you have ischemia reperfusion injury. This is part of the hypoxia syndrome. And once that blood flow reestablishes itself, it can set off another chain of events with more platelet adhesion, thrombin generation, and microthrombi, coronary heart disease, and plaque formation. The point to make here, I think, is that the glycocalyx dysfunction precedes damage to the endothelium. So we've got to develop treatments that protect the glycocalyx, but also protect the endothelium. This is a very nice electron microscopy. You can see the intact glycocalyx here. Looks like kind of a sugar coating. Here's your endothelium right here, and then there's the vessel lumen. Now, if the glycocalyx is damaged, you can see it's in total structural and in functional disarray, and then actually the endothelium begins to look very bad as well. So you need to know why the glycocalyx becomes damaged. Diabetes, or just high blood sugar, oxidized LDL, increased LDL, particularly small dense LDL and triglycerides, thrombin, inflammatory markers and cytokines like TNF alpha, and then the three finite responses: inflammation, oxidative stress, and vascular immune dysfunction. Volume overload, low shear stress, which typically occurs at the bifurcations of arteries, hyaluronidase, which breaks down hyaluronic acid, increased levels of matrix metalloproteinases, which will damage all of the proteins, ischemia, reperfusion, atrial natriuretic pepper, and endotoxin. So there's a lot of things that will damage the glycocalyx that you can prevent directly by treating the underlying problem, but also ways to actually improve the glycocalyx itself, both functionally and structurally, which we'll talk about. Now, the glycocalyx dimension is going to vary depending on the type of artery that it's in. It also will change size depending whether it's in the bifurcations. And that's the area where most atherosclerosis occurs, which is at the bifurcations. So a low shear stress where there's decreased blood flow reduces nitric oxide production, and that in turn leads to endothelial and glycocalyx dysfunction. So this is now clearly an intervention for cardiovascular disease. Endothelial dysfunction, glycocalyx dysfunction have similar etiologies as to what causes damage, and we need to address all the upstream problems and then also try to protect anything downstream that we can and make it a healthier system. So this has led us to identifying what are called glycocalyx regenerating compounds, or GRCs. Basically, these are from polysaccharides. They're very similar to glycoaminoglycans. They're marine-based and have shown to have improvement in cardiovascular health. And the patented product by Calroy is called Arteriocel, and it has been shown to have dramatic effects on glycocalyx function, structure, and also, as we'll hear shortly, to have improved effects on cardiac artery, IMT, plaque formation, and possibly other areas in the vascular lining. This shows you what blood sugar can do, even within normal levels. And most of you know that blood sugar fasting starts damage at a level of 75 milligrams per deciliter. So it doesn't take long for the glycocalyx to start to look very bad. So here's the normal glycocalyx here at the top, and then this is one that's damaged in the presence of high blood sugar. Diabetes is one of the primary reasons to damage it. But if you look at different dosages of glucose, here's the normal endothelial glycocalyx over here, and then you have glucose. You can see there's damage, and you can have different doses as you go across here. But the point is, it's not just the level of glucose that's the damage, but it's also the duration. And if there's confounding variables that you add to the blood sugar, the damage is even worse. There's some studies which you'll hear about related to plaque regression and carotid IMT, carotid MRI plaque view, which is very promising for reducing atherosclerosis. And most of you know there's various types of plaque. Vulnerable plaque typically has a very thin lining, has a lot of cells inside that are culprit cells with inflammation, oxidative stress, and vascular smooth muscle cells. And those are the ones that tend to rupture, releasing all of those very nasty compounds into the vascular lumen and causing acute thrombosis. In fact, most myocardial infarctions actually occur in non-stenotic plaques, meaning less than 50 to 60% obstruction. So the vulnerable plaque is the one that we need to address by trying to get it to a non-vulnerable or stable plaque by reducing the intravascular risk for thrombosis, but also trying to calm down all the atherosclerotic compounds, the inflammation, the smooth muscle cells, and the immune dysfunction that's occurring within the plaque. So you try to make the cap thicker and reduce the rupture-prone inflammation that's within the plaque below. So plaque view is one of the best ways that we now have to actually look at carotid plaque and look at what's actually composed, whether it's the lipid core, the calcification, whether it's hemorrhaged. And this is probably a major breakthrough now in the ability to determine risk for stroke in these patients. This is an example of the plaque view. Here's the carotid artery over here, and then you can see the actual plaque view here. The white would be calcification, the pink is loose matrix, the red is hemorrhage, and the yellow is lipid-rich core. This is a pretty nasty type of plaque, and when that ruptures, typically at the shoulder areas right here, all of that spews into the lumen and causes acute thrombosis. So over time, the carotid arteries adapt. They get thick, then they start to get the plaque formation, and eventually it goes into a very serious vulnerable plaque with all these nasty goodies in it, and it can actually rupture then and cause problems. Once it's calcified, as this one is, the risk for rupture is actually very low, but the risk of obstruction is much higher. So you can see the lumen here is much smaller with the calcified plaque. So this would be an obstructive lesion with stable plaque, and this would be a fairly non-obstructive lesion with vulnerable plaque. And this is the one that actually causes most myocardial infarctions, not the one that's calcified. So arteriocele has actually been shown to cause plaque regression, and it's fairly significant. You can see here in women decreased by 64%, and in men decreased by 46%. That's actually more impressive than some of the drug studies, for example, with the statins. And it's very quick. The study, this can happen in several months, sometimes 2 to 4 months, up to 6 months, the plaque is actually starting to regress. So you can see that everything gets better, the lipid-rich core and the arterial thickness, IMT. So this is very promising data. We may have something now that's actually incredibly helpful to reduce stroke by reducing plaque formation. There's a lot of studies that are going on, so we'll have more data, and that's going to be presented today, but also later. This is some of the studies. I won't get into these in great detail. They'll be covered in our next lecture. So the average reduction in lipid-rich core is about 56%, with an actual increase in lumen size and a decrease in actual stenosis of the artery. This is an interesting article looking at the endothelial glycocalyx that's impaired related to sodium, the epithelial sodium channel, and aldosterone. What we found is that the epithelial sodium channel is not only important in causing increased intravascular volume through the kidney, but it increases sodium increased in the vascular wall, which then causes endothelial dysfunction. And if you have a high aldosterone level associated with that, there's even more vascular damage. So you get stiffness, nitric oxide falls, the endothelial shrinks, the microcirculatory system is dysfunctional, and the myocardium suffers with LV dysfunction. This is a study that we did looking at blood pressure response using arteriocele. It was a small study, but it was a significant study showing significant reductions in systolic particularly, and if we'd had probably more patients, a significant reduction in diastolic as well. So we think that arteriocele is actually going to be a non-drug treatment for hypertensive patients, and at the same time can improve arterial health and improve nitric oxide levels. So a lot of the material that we've talked about today is published in this book, which is brand new. It just came out in January of 2020. It's a multi-authored text. I had the pleasure of being the editor for this. So if you're interested in purchasing this, you can get it on Amazon. And I thank you all for your attention, and I will sign off and turn it over to our next speaker, Dr. Christine Burke.
Thank you very much, Mark, and my appreciation too to Calroy Scientific and to Ovation Labs and my esteemed colleagues. I'm very honored to be a part of this group. I have a membership hybrid practice in Northern California, and we do both primary care, comprehensive primary care from a functional medicine perspective, as well as consultative functional medicine. And so we have several disease reversal programs like diabetes reversal, dementia reversal, complex chronic illness treatment. So we have a wide variety of different conditions that we work with. But one of the things we offer as part of our primary care membership is this comprehensive cardiovascular disease wellness assessment. And so that includes an advanced lipid profile with the particle profile and the inflammation biomarkers, as an assessment of endothelial function, and a carotid CIMT and plaque assessment. And so I first learned about Arterosil at the annual international conference for IFM last year. And I was very excited about the data that I was looking at and the potential application for my patients, particularly some of the more difficult patients that I'd been doing work with them from a functional medicine perspective, working on their root causes and their inflammation and their nutrient status, all of the things that we all do. But I hadn't really gotten a lot of traction. I'd had improvement or maybe had kept them stable, which I think we are all aware that the normal progression is for CIMT to thicken over time as we age and for plaque to progress if we don't do anything to intervene. So even keeping someone stable is an accomplishment, but of course I wanted more. I wanted regression. So I talked to Ed Hoyt, who's the CEO of Calroy Scientific, at the conference, and we were talking about doing some clinical research, and that of course takes some time to get going. And when I got home, I was hot to trot to try this new product, this new frontier in addressing the endothelium. And so I selected a bunch of my patients who had been some of my most difficult to control patients, and I started them on Arterosil. And this is the result of my first patient. So this is a 71-year-old female. Hang on, I gotta move this out of my view here. Okay. So this was a 71-year-old female. I've been working with her for years. She's been more or less at the same level. I mean, you can see over here in the arterial age that we've kind of bounced around a bit, but she's done fairly well over time. This is where we had ended up. A couple of years ago, we got improvement, and then I started her on Arterosil, and 3 months of Arterosil resulted in this huge improvement where she had this big reduction in vascular age, and she had resolution essentially of the plaque on the right and near resolution or significant improvement of the plaque on the left. So that was pretty interesting. Then, I'm having the same problem as Mark. Answer my slide. There we go. Then this result was the next one that came across my desk, a 52-year-old female who started off over here with a vascular age of 69 at the age of 51. And after 6 months of Arterosil was over here with a vascular age or arterial age of 66 and notable reduction in plaque again. And then the third one was this 47-year-old male who had a significant reduction in vascular age of 6 years after just 6 months of Arterosil. So that was all very, very interesting. And once we started talking about doing the clinical trials, I suggested that we do a retrospective data analysis of the patients that I had started on Arterisol the year prior. And so we selected, well, I selected 10 subjects, more or less randomly, just from a list of people who had purchased Arterisol after it being recommended. They were all people who'd been multiple years in my practice with hard to reverse plaque. And if you look at this Arterisol usage data, it's kind of all over the map. I mean, people used it anywhere from 4 months of use to 11 months of use over between a 9 and a 12-month period. And so at first I was thinking that this was really haphazard data, but it's kind of how clinical practice is, right? Our patients don't follow our recommendations to a T. They don't do exactly what they say, what we say, or they have a hard time with their ongoing compliance. Nonetheless, we had pretty remarkable results in that data. So we have data on 6 of them that's presented here. And this particular table is the maximal right plaque thickness, so the maximal wall thickness from the studies that Dr. Houston was showing. And so I have an example over here. So for example, in this particular image, the maximum plaque would be this 2.072 plaque, just so you know what the data is that we were looking at. So between our visit 1 and visit 2, which was those random intervals that I mentioned earlier, we were still able to accomplish a 52% reduction in the plaque on the right-hand side. And on the left-hand side, it was even more substantial, with this reduction in plaque of about 65%. I can't move the thumbnails out of my view. I'm pretty sure it's 65%. And that reached statistical significance even with this small number of participants. So that's very, very impressive. Then we looked at what we called total plaque burden. And that was calculated by doing the sum of all of the plaque locations for both the right and the left-sided arteries and combining them together, comparing visit 1 to visit 2. And in that group, we also had almost a 54% reduction in plaque, which was very exciting as well. And what I thought was very interesting is that although this is clearly not as precise a measurement, I would say, as the MRI plaque view study is, we were still able to accomplish very, very similar results with, you know, kind of real world clinical participation, which is really exciting. This one barely missed the statistical significance for the p-value. So hopefully when we have more of the subjects involved, we'll be able to reach that. So now we have the prospective study underway. And for this group, we selected 10 participants from the community. So they're not people who are already receiving functional medicine care. And they're going to be taking Arterisol for 6 months and 6 consecutive months this time. So it'll be interesting to see how perhaps the data may improve or be the same. But any way you slice it, I'm very excited about how this is looking to accomplish plaque regression in the clinical setting. So happy to be a part of this for sure.
We'll also introduce at this moment Dr. Chen Chen, who has just shown up on screen. Chen is the Chief Science Officer for Calroy. Welcome, Chen. And let's also bring on Ed Hoyt, who is the CEO and President of Calroy. And we'll have an opportunity to field some of these questions. So I think if you'll all allow me, welcome Ed, if you'll all allow me, I will try and direct the questions a little bit. So Mark, I think we'll start with you. There are a couple of questions about whether or not Arterisol could be safely used if stents are already in place, and also a question about use of Arterisol in anti-phospholipid syndrome. So would you like to offer a response to those questions?
Arterisol should be able to be used safely in stents to reduce stent restenosis. Excuse me. And also, it should be able to reduce all the consequences of the antiphospholipid syndrome. So, yes to both.
Terrific, thank you. And then Chen and Ed, but maybe we'll give this to you, Chen, first. There are a number of questions that all roll up into How much arterisol should people be taking? How long might they take it for before they might see some kind of an effect, plaque regression? What happens if you stop taking it? And are there side effects? So maybe you could address that batch of questions.
Sure. Thank you, Laurie. That's a great question. We've studied arterial for quite some time and had a lot of experience in the clinical side. Depending on the conditions you're looking at, if we just look at the effect of the compound, it can be very fast. If you look at the endothelial function, for example, in one of the studies we did look at the arterial elasticity, we show an acute effect in a few hours. However, with some of the disease conditions, it takes longer. So we're looking at a month or two to see benefits, and sometimes even longer, like Dr. Houston indicated in the plaque regression, depending on the severity of the condition, it could take a few months or more. As far as safety goes, in the human study, we didn't see any severe side effect. We look at the different things, the metabolic markers. However, those are the healthy individuals. And in clinical experience, we haven't got any report of severe side effect as well. So the bottom line is, yes, it could take days and weeks or months, depending on the condition. For some more severe conditions, I would say a couple of months to see the benefits.
Okay, and then if you mentioned it, I apologize. I was probably looking at the Q&A. Any contraindications or side effects?
No, we haven't really seen any. One of the concerns is about anticoagulant activity of arterisol. We look at that in one of the human studies. We look at the blood coagulation. Again, in a fairly healthy population, and with a couple of months, we don't see any changes. And again, the product, Mark answered the question about the stents. We have fairly amount of patients who had stents, multiple stents on arterisol, and they monitor their blood coagulation, and we haven't seen any. The data we're aware of, there's no contraindication.
Great. Does anyone want to comment on any of Chen's remarks? I can certainly go on to another question, but sometimes you're sitting there with a comment you'd like to make. So I just want to make room for anyone else. Ed, would you like to
yeah. Part of that question was how long should somebody stay on arterisol?
Yeah.
And I thought that would be great for Dr. Chen to address.
Oh, okay. Yeah, one thing to add about anticoagulant activity, what we've found in some of the study, animal study, is that anticoagulant activity is mainly associated with the endothelial wall, which means the endothelial glycocalyx. As far as the duration of the therapy, again, all those factors Dr. Houston mentioned that would damage endothelial glycocalyx. I think we need to have them under the control. Otherwise, you probably want to take the product either as a preventive or a treatment. So it could means that someone need to take this for a pretty long time.
Laurie, could I jump in here?
Yeah, because I was going to actually ask you, Mark, when you answer, please also include, there's some questions here about whether physicians would have to recommend their patients stop taking other forms of anticoagulation.
Yeah, I just saw about 10 pop-ups on
Please.
the safety of other anticoagulation with arterisol. I think we have to be clear that arterisol is not an anticoagulant, okay? Arterisol is going to replete the glycocalyx to prevent thrombosis. Therefore, if you're on Plavix, Coumadin, a factor 10 inhibitor, like Eliquis, whatever, you're not going to see really an increased risk in bleeding on arteriosol because it's not really causing an increase in anticoagulation. So that's it's sort of like saying, well, should I take a natural compound like CoQ10 or curcumin with Plavix or aspirin, because everybody's out there are so worried that they cause coagulation difficulties. They don't. They're just protecting you from getting coagulation. Unless someone else knows something different that I don't know, I have no problem using Arteristil with any anticoagulant.
Anyone have any other perspective you'd like to add?
I would just concur with what Dr. Houston was saying, and from the perspective of when to think of it or when to use it. You know, from my perspective, the most common feature of people who show up in a functional medicine clinic is an inflammatory process that is a kind of a convergent endpoint from any of several upstream factors. And when a person has systemic inflammatory process, you can expect that that's going to affect their cardiovascular system, whether they're arriving in your clinic with that in mind or not.
Yeah. Yeah.
I would agree. At least clinically, I haven't seen any issues with using it, and I haven't altered dosing for anyone who is taking an anticoagulant.
Okay. And Mark, another question we'll bring back to you is, as one of the attendees is asking about, would Arteristil be appropriate for someone with resistant hypertension? And again, we saw some of your hypertension cases. I'm not sure that we did mention we're intending to collaborate with you to continue the the hypertension study, but can you comment on that?
Sure. You can use Arteristil in any hypertensive patient, but you're not going to get the reductions in blood pressure that you need with just a natural product. You've almost always got to use a drug along with a natural product to get the blood pressure controlled. And it's very important that you realize that the sooner you start drug therapy with natural therapy to get the pressure down to the idea that you want around 120/80, the better the patient's going to do, because once they get to that level, you know, the risk goes down, and then they don't have to play catch up the rest of the time.
Mm-hmm. Mm-hmm. All right. Thank you, Mark. I think we'll keep going here. Christine, this was not a direct question, but I know it's something that that was really interesting to me as we've talked over the last week or so getting ready for this. And I think it was very interesting that you had these 3 cases. You started to see some interesting findings, which caused you to then want to take a look at the retrospective, which is now leading to the prospective study. So maybe just take a minute and, you know, as a clinician, help us understand what you are seeing that you think is both interesting and where you want to dive in a little bit more.
Sure. So when you're working on the inputs of inflammation and you're working on the blood sugar control and the nutrient repletion and the antioxidant, anti-inflammatory foods and supplements, and you're seeing just this, you know, more or less static result, it's really fantastic to have something like this that's really getting at exactly what we want, right? The root cause. So damage of the endothelial glycocalyx is what leads to vulnerability in part for more plaque production. And so being able to have something that we can intervene with that helps to heal that. I know Dr. Yannick in the Cogent's immunology training, you're always talking about if we address a few things well, but we don't get at the whole picture, then we don't have the same level of result or response. And so I feel like having this to address the glycocalyx specifically, which we're really doing indirectly with our other interventions by trying to take away what's creating the damage, which is important, of course, but you need the buildup, you need those building blocks to be able to restore it. And that's where I think it really has its power.
Yeah, thank you, Christine. That's helpful. I think we'll switch gears for just a minute. We're getting close to the top of the hour, but there have been several questions wanting to understand biomarkers and how are you all measuring improvements to or effects of Arteristil and improvements of the health of the endothelium or endothelial glycocalyx. So Chen, why don't we start with you, and then we can hear from a couple of the clinicians.
There's different things you can look at. Obviously, some markers are more specific to disease. Some more general marker we looked at in the past in some studies that we've seen certain response. For example, the general inflammatory markers like CRPs and interleukin-6. We've seen some changes in the past. And another one as promising is microalbumin, indication of the microvascular damage. Endothelial function is another one, and flow mediated dilation. We've seen some in the past, and arterial elasticity. The more specific markers related to the atherosclerosis, like we've talked about so far by the speakers, like carotid IMT and also plaque view. So those can also be used, but there are many blood markers that could respond, but depending on the underlying conditions and interaction factors. So we may or may not see things very specific, but I'm pretty sure Dr. Houston and Dr. Burke may have other things to say about those.
Yeah, let's give all of you, Mark and Christine and Sam, just a quick moment to say what other kind of biomarkers or labs or diagnostics that you're using or that you would consider as it relates to measuring vascular endothelial health and the effects of arteriocele. Mark?
Yes. So we in the Hypertension Institute, we have a whole group of non-vascular tests that we use. One is called a endothelial lining nitric oxide testing, and it's EndoPAT. That's very accurate. Then we have computerized arterial pulse wave analysis, which measures arterial elasticity, both in large and small arteries. We have another test called ATCOR, which measures what's called augmentation index, which is a reflected wave in the entire arterial system. Then we have plethysmography, which is through iCloud, which looks at coronary artery elasticity and vasospasm. So those are the non-invasive things. And of course we do, echoes and carotids and all the other things. And as Chen's mentioned, a lot of the vascular blood markers, and in addition to interleukin-16, CRP, myeloperoxidase is important. And then we've got a group of labs, PULS and CHORUS, which we use to validate risk for future myocardial infarction and obstructive coronary heart disease. So, and I could go on. There's, literally about 40 or 50 different things that we do in the Institute that measure all these criteria.
Thanks, Mark. Christine?
So in a much smaller setting, right, clinical private practice, we do the LPPLA2, myeloperoxidase, the HSCRP, microalbumin creatinine ratio, and the ADMA for a blood marker for endothelial function and robustness of nitric oxide production. Those are the main ones.
Sam, anything to add?
I would concur, and I would just add glyc-A to that mix. And also really, for me, a lot of it is when I think I'm earlier in my cycle of understanding of all this than my esteemed colleagues, certainly. This for me is something that I'm coming to probably a decade later than I should have, and sort of merging over from immunology into an appreciation of this whole area. So I think for me, I really come at it more from the point of view of clinical observations about vascular integrity that are about things like physical exam and so on, but also a realization in some patients that when the things that should have worked didn't work, that what's happening is, as I said at the very beginning, you can craft an excellent program to address something that you're not thinking of as cardiovascular or not thinking of as having a cardiovascular component. But if tissue delivery of those substances is not optimal, you say to yourself, well, okay, I did these things and I expected a certain result. That result was not forthcoming. What I've learned over the past phase of time is, okay, I've got to think about whether these components are actually being delivered to tissue. I've got to think about whether this patient is marginally hypoxic. And then when I begin to address that and the patient turns around, I get corroboration that, okay, it was really clinically quite worthwhile to attend to this patient from a cardiovascular point of view that I hadn't considered before, because that wasn't what they were asking me to do. But nonetheless, it turns out that that was crucial for me to do so that the rest of what I'm considering for them can work.
Well, Sam, that was actually a beautiful segue, because not only are you a very, very accomplished immunologist, but maybe we'll add psychic to the list, because I was just about to invite the three of you to make a sort of a summary statement and wrap up as we close here. So anything else you'd like to add to that? Because I think that was actually a very nice pulling together of a lot of perspectives, both things that have been covered here, but also how you think about and approach these kinds of problems and issues in your practice.
I appreciate it. I mean, I think it's very much, as I've said. The other thing I would say is, as a person who's got Dr. Houston's book, which is now much dog-eared, it's a good book, and I would use it as a vehicle for, digging in, and these kinds of things get absorbed over time, right? So that's how I'm doing it, certainly.
Great. Mark, would you like to make just a wrap-up statement, comment?
Everybody has done a great job, I think, covering this topic. So one real last pithy statement that I would say, the glycocalyx and the endothelial lining are now the priority in establishing both prevention and treatment in cardiovascular health. And we've got the techniques to measure those, both blood and non-vascular tests. And we have the two treatments now with arterosil and other agents that improve nitric oxide. And the combination of those two, I think, is going to be powerful, but yet to be studied. And I hope that we get that done quickly.
Well, Mark, thank you. And Christine?
I would just say that I think it's really gratifying to have something as safe as arterosil appears to be and as effective as it appears to be in our hands clinically at such an early stage in this process. And I've noticed that there were a lot of questions about PlaqueView being clinically available. And Mark, you may be able to answer this better than I. I believe it's still just available as a research tool, but CIMT is readily available. And we're showing that we are able to achieve similar results that can be measured by CIMT, and literally any of us can order that test. So it's so useful to have this available.
I think we'll close now, and I want to extend on behalf of Calroy Health Sciences our tremendous appreciation and gratitude to Dr. Yannick, Dr. Houston, Dr. Burke, as well as all of you, more than 100 of you who have joined us live for this webinar. Thank you so much for your time. Thanks, Ed and Chen, for joining us in the Q&A. Really important to have both of you here, and many, many thanks. Good evening.
Thank you, Lori.
Thank
Thank you.